Hello, everyone. So, today I'll talk about vasculitides. It was always a confusing topic for me in school. So, I'll hope to make this as simple as I can and try to fix in all the details that are important to know. So, this is what we'll look at. We'll define the systemic disorders called vasculitides. We'll look a bit at the pathology. Uh, we look at the patterns of signs and symptoms because this disease follows patterns. It's not textbook that this will happen. With this disease, these are the signs and symptoms that will manifest. But it's rather a pattern that you can use to identify and diagnose vasculitis. We'll look at the main defining clinical manifestation. These are one of the things to look out for when you're thinking of vasculitis in a patient. We'll classify it. There's primary and secondary vasculitis. Uh, we'll look at a few major ones, just a brief overview so that you can get familiar with it in case you find it. We look at mimics of vasculitis. These are diseases or disorders that are not exactly in the category of vasculitis but resemble vasculitis. And then diagnosis and then treatment. So it's a group of systemic diseases that mainly cause inflammation of blood vessels. So it's mostly autoimmune in nature. Vascular from the word vessel and itis, which is inflammation. So just from the name, vasculitis is inflammation of the blood vessels. And usually this is autoimmune. That means the body's own immune system is attacking your blood vessels. So the pathology, the main cause of inflammation and what the process that occur leading up to inflammation of the blood vessels, it's endothelial damage, usually by antibodies from your own body. So endothelial damage will lead to the smooth muscle inside the blood vessel, the endothelium, to proliferate. Also, endothelial damage causes the exposure of the endothelium, and when endothelium is exposed, it becomes a procoagulant. It activates the coagulation system, so there is a lot of thrombosis. And all this together, the smooth muscle proliferation and the thrombosis, cause narrowing of the blood vessel. And if there is narrowing of the blood vessel, there will be less blood flow to whatever organ that blood vessel is supplying to. So it usually ends up with end organ damage if it goes untreated. So we can classify vasculitis in different ways. One of the ways to classify it is using the size of the vessel that it affects. So large, medium, and small. So large vessels, the large vessel vasculitis is Takayasu and giant cell arteritis. We'll look at this again, just briefly in the later slides. So large vessel is Takayasu and giant cell arteritis. Medium vessels. So by large cell, I mean Takayasu, for example, affects the branches of the aorta, which are large vessels. Giant cell arteritis affects branches of the carotid, mainly the temporal artery. So it's also called temporal arteritis, and it affects elderly people, as we'll see. So medium vessels is Kawasaki and polyarteritis nodosa. So Kawasaki mainly affects the coronary arteries of the heart. Polyarteritis nodosa can affect mostly all vessels of the body, medium sized, usually kidneys, and it has an association with hepatitis B, as we'll see. Small vessels now, these are the arterioles and the capillaries and the venules. So we divide small vessels into ANCA associated. ANCA is anti-neutrophilic cytoplasmic antibody, and then there is immune complex associated. So ANCA associated small vessel vasculitis is granulomatous polyangiitis, which used to be called Wegener's. The name was changed because Wegener was a Nazi physician. Eosinophilic granulomatous polyangiitis. Now, this used to be called Church-Ross, and there is microscopic polyangiitis. We'll look at this later. And then there is immune complex. This is still part of the small vessel vasculitis. So, immune complex associated, the most important and the common one is IgA vasculitis. And then there's cryoglobulinemic vasculitis and hypersensitive vasculitis. So, the patterns of signs and symptoms. So, This one we can look at it in terms of the size of the vessels affected. It'll be easier. So small vessel, if the vasculitis affects the small vessels, this will be the patterns of signs and symptoms. So vasculitis, as I said, it can affect all parts of the body, but the main systems that any vasculitis will affect is skin, GIT, muscle, the CNS, and the kidneys. And the manifestations vary depending on the size of the blood vessels, but it's not written in stone. Sometimes small vessel vasculitis can present with symptoms that a large vessel vasculitis might have. It intertwines, but basically this is the blueprint of how it affects different organs. So in small vessels, for the skin, it will cause a palpable purpura, which is just purplish spots, bruises like things, usually in the lower limbs. In GIT, we have mucositis and a bit of GIT bleeding. Muscle, we have myalgia, which is muscle pain. For CNS, we have polyneuropathy, which means like your nerves of your body are affected. It can cause paresthesias, a pins and needle sensation. It can cause a bit of paresis, but not as much as a medium vessel and a large vessel vasculitis will cause. But mostly it's the numbness and the pins and needle sensation that we get. It's called paresthesias from the polyneuropathy. And the kidneys will cause hematuria. It can be either microscopic or gross hematuria. Medium-sized vessels, again, the same organs. So skin, it goes livedo reticularis, which is like a net-like lesion. It's much wider spread than the purpura, and it's like you have a spider web kind of thing, purplish lines in your skin. GIT, abdominal pain and abdominal perforation. Muscle have myositis. Remember, in small vessel we just had myalgia, which is just means pain. Myositis means inflammation, which can be seen in a microscope. For CNS, now we have CVA, which is cerebrovascular accident. Usually, one of the most common CVAs is a stroke. So, because it's a medium vessel and the branches of the carotid and the meningeal arteries and the cerebral arteries, they are medium sized, and if they get blocked, you can manifest as a stroke. Also, mental state changes. And for the kidney, we have hematuria with flank pain. Large vessels, skin. Again, now we have it goes the larger scale, so it's cyanosis, which is bluish discoloration of the skin, and mucosa. GIT, now we can have abdominal infarction. Sorry for the spelling. For the muscle, we have claudication, which means there is intermediate lack of blood supply. So whenever you walk, you feel a lot of muscle pain all of a sudden, and then it gets better when you rest. That means there's blockage of the blood supply to the muscle, so the muscle is getting starved of oxygen and nutrients. So whenever you put an extra demand on that muscle, it start paining. CNS, again, the same, stroke and mental state changes. And kidneys now, because it's a larger vessel is affected, you can have hypertension. Usually if the renal artery is affected, you'll have hypertension. So these are the main defining clinical manifestations. Whenever you see these in a patient, you should think of vasculitis first and then try to rule it out. So palpable purpura, again, as I said, bluish, I mean, bruise-like discoloration of the skin. It's purplish in color. Livedo reticularis, again, net-like lesions on the skin. And then any disease which affects both the lungs and the kidneys together. Usually, you should think of vasculitis should be one of your main differentials. There is vasculitis and there is the Goodpasture's disease, Goodpasture syndrome, which is also called the anti-GBM, anti-glomerular basement membrane disease. Some guys put this under vasculitis, some guys put it as its own thing. So it depends. It doesn't really matter as long as you can identify what it is. So any patient presenting with pulmonary renal complications, think of an autoimmune disorder, usually vasculitis. And then mononeuritis multiplex, just from the it's a big word, but we can break down the words. Mononeuritis, which means one nerve and in multiple areas. So let's say if the ulnar nerve is affected, you'll have the medial fingers, you'll have paresthesias, you'll have weakness. And then let's say if the, so that's one. Multiplex means another one will be affected together. Let's say now we have the peroneal nerve. Common peroneal nerve is affected, you'll have foot drop. So if you have presenting with ulnar neuropathy, peroneal neuropathy, maybe even radial neuropathy together, so you have the wrist drop. So this forms the whole complex called mononeuritis multiplex. So if you get patients with that, different nerves affected in different areas of the body randomly, so think of vasculitis. So there is, okay, we've done this. So there is so the classification that we looked at, the large vessel, medial vessel, and the small vessel with the anchor and the immune complex, that's primary vasculitis. Usually primary of any disease means there's no other underlying cause. So that's it. Like for example, primary hypertension or essential hypertension means that that's the main disease affecting the body. There is no underlying cause causing that hypertension. Same with vasculitis. Primary vasculitis means that's it. That's the disease. Secondary vasculitis means there's something else which is leading to a vasculitis. So connective tissue disease like SLE and rheumatoid arthritis are one of the big causes of vasculitis. We have malignancies like leukemias and lymphomas, and infections like HIV and hepatitis C, which can cause secondary vasculitis. So we look, as I said, we look a bit at the different primary vasculitis. So Takayasu, it's a large vessel vasculitis. Large vessel as in why? Because it affects branches of the aorta. And the epidemiology of the disease is usually it occurs in young Asian females. So young Asian females presenting with a vasculitis affecting the branches of the aorta, think of Takayasu. And one of the most interesting presentation of Takayasu is you have pulseless disease, which means you can find that when you try to check for a pulse in, let's say, in the arms or in the legs even, you won't get the pulse. Why? Because the aorta is mainly in the arms. The aorta is the one that supplies the rest of the body. Or most of the branches of all arteries in the body branch off from the aorta. So if you have inflammation, thrombosis, intimal proliferation, and narrowing of branches of the aorta, that means blood is not going to those extremities, those end organs. So you are testing for the pulse in the hand, in the wrist of the right hand, you won't find it because the branch of the aorta supplying that part is blocked off. So it's a common and interesting presentation of Takayasu, which is pulseless disease. Giant cell arteritis usually affects the elderly. And as I said, it affects the temporal arteries, can usually present with a throbbing temporal headache. Kawasaki, as I said, branches of the aorta, affects the coronary arteries, and it's usually seen in children less than 5 years, and it presents with coronary artery aneurysms. Aneurysms means there's weakness of the blood vessel wall and there's bulging because of the weakness. Polyarteritis nodosa, this one affects a variety of different organs, and one of the most common presentations is weight loss, livedo reticularis, aneurysms, usually at places of the arteries where there's branching, and then interestingly, it's associated with Hep B. So once you get hepatitis B, you should look out for polyarteritis nodosa. Now, ANCA associated, this is again a part of the small vessel vasculitis. We had the ANCA and the immune complex. So for ANCA, as I said, this is Wegener's granulomatous polyangiitis. So this one will affect the kidneys, will affect the lungs. Usually kidneys will affect hematuria, and for the lungs it will be alveolar hemorrhage. And then upper airway, which means the nose, the mouth, and sometimes even the ears. So you can present with epistaxis, you can present with stridor because of this blockage of the trachea. You can have also otitis media. You can have nasal, the nasal obstruction, and also nasal bridge collapse. So eosinophilic granulomatous polyangiitis, which is Chuck-Strauss, used to be called Chuck-Strauss because of eosinophilia. From the name, you'll have peripheral eosinophilia and asthma Also neuropathy and upper airway disease. Microscopic polyangiitis is the same as granulomatous except there is no upper airway involvement. And also of note, because the reason it's called microscopic means when you tish, uh, cut out that part of the blood vessel to observe under the microscope, you won't see granulomas, the ones you will see in the granulomatous one. You will see microscopic evidence of inflammation, however, you won't see granuloma. That's why it's called microscopic polyangiitis. IgA vasculitis is common, especially among kids. So these four things are they usually come together, and you have to look out for them when you're dealing with IgA vasculitis. It's also called henoch-Schönlein purpura, but now that we just use the name IgA vasculitis, it used to be called henoch-Schönlein purpura. So you present with arthralgia, which is muscle pain, joint pain, hematuria, abdominal pain, and palpable purpura, especially in the lower limbs. It's self-limiting. However, it needs admitting in severe cases, and it affects mostly children. So mimics means conditions that are not actually vasculitis, but they resemble vasculitis. DIC, disseminated intravascular coagulation, resembles vasculitis. Goodpasture disease, as I mentioned earlier, which is also called anti-glomerular basement membrane disease. It affects the basement membrane of the glomerulus, also affects the alveolar membrane, so can cause hematuria as well as pulmonary hemorrhage. Sarcoidosis, a systemic inflammatory disease, which is usually uh, classically presents non-caseating granulomas. We have Behçet's disease. It's a connective tissue disorder, usually present with the three things that are typical of Behçet's disease is mouth ulcers, genital ulcers, and uveitis. And then we have amyloidosis, which is when there is improper unfolding of proteins, so they precipitate in places where they should in tissues. So investigations, again, CBC, we need to see if there's any high white cell count. You can have also low platelets because one of the differences is DIC. Coagulation profile, again, it's important because DIC is a differential. Again, the autoimmune markers anchor for obvious reasons. ANA is for ruling out lupus, SLE, which is one of the causes of secondary vasculitis, and then anti-rheumatoid factor, again, because it's causes secondary vasculitis. MRA, which is MR angiography, CT angiography, and carotid Doppler ultrasound. This is to check for any narrowing of vessels because that's the main pathology of vasculitis. And then biopsy is confirmatory. You cut out that part of the vessel or the organ. You look in the microscope. If you see inflammatory cells, uh, that's a gold standard diagnosis. Sometimes you even use immunofluorescence, especially in diseases like good pastures. So biopsy is the gold standard for diagnosis of vasculitis. So treatment, depending on the severity of the vasculitis. So if you have mild, just a bit of skin lesions, purpura, you can just put them under the observation. You can, if it's too symptomatic, you can just go for antihistamines and sometimes prednisone. Moderate disease, you put prednisone, which is a steroid. Obviously, corticosteroids counteract inflammation, so the antidote for inflammation would be steroids. So prednisone is used. And if you have severe vasculitis, life-threatening, causing end organ damage, you use high dose prednisone. Also use immunomodulators like cyclophosphamide, azathioprine, methotrexate. And if things are really, really bad, plasmapheresis, which means just you run your plasma through a machine and all the antibodies are sucked out. So basically, there's nothing to attack your vessels. Yes. So that's vasculitis for you. I hope now it makes better sense because it does to me. Thank you.